Hey guys, it's Brittany again, giving you a full cardiology lecture. This PowerPoint will probably be a little longer than the last time. Hopefully, I will be able to get through it in less than 45 minutes. So I'm going to probably go pretty quickly through things. Again, if you have any questions or concerns, you can contact me or we can discuss later when we meet on May 29th. So objectives for this presentation, we're going to review CAD, heart failure, arrhythmia management, and peripheral vascular disease. We'll have a short overview of some cardiac testing, what that testing is, and when to order. First, we'll start off with some anatomy slides. Knowing the anatomy of the heart is so important to completely understand the cardiovascular system. So remember, the heart, within the heart walls, we have three layers. We have the pericardium, the myocardium, and the endocardium. We have chambers of the heart. We have the atrium, which is the top upper chambers of the heart, and there is the right atrium and the left atrium, and then we have two ventricles at the bottom part of the heart, the right ventricle and the left ventricle. We also have four valves within the heart: pulmonic, tricuspid, aortic, and mitral. We will go over cardiac anatomy further in lab. I'm hoping to have some pig and sheep hearts that we can dissect that will give you a little bit understanding exactly of what the heart looks like. I believe that the anatomy is the most important aspect to know to understand cardiac function. Also important is to know cardiac hemodynamics. Remember, cardiac output is stroke volume times heart rate, and stroke volume is the volume of blood pumped out of the heart with every heartbeat. It's anywhere between 50 to 100 mLs. Three factors affect the stroke volume: contractility, preload, and afterload. Preload is how much blood is in the left ventricle before the contraction of the left ventricle. This is also given the term end diastolic volume. Afterload is the pressure required to open the aortic valve. It's the force against that the heart has to beat. We have systemic vascular resistance, or SVR, and PVR is the pulmonary vascular resistance. To understand cardiac hemodynamics, you have to go back to your pathophysiology times and remember the Frank-Starling curve, and then the Frank-Starling relationship to exercise and how that affects the heart function. For your cardiac assessment, again, you need to obtain a thorough history. You'll want to do a thorough review of system, including chest pain, dyspnea, palpitations, dizziness, lightheadedness, syncope, abdominal distension, orthopnea, and PND. You need to observe the general appearance of the patient. Do they look ill? Very sick cardiac patients look very sick. We also will obtain vital signs, EKG. You want to inspect the skin. Is it warm and dry or cold and clammy? You want to inspect the cap refill, auscultate heart tones, and auscultate breath sounds. When we're listening to cardiac auscultation, you're listening for clicks, rubs, and murmurs. We have systolic murmurs and diastolic murmurs, and you're also listening for S3 and S4 sounds. Here's a table that describes the different heart murmurs and when we will hear them, and if they're systolic or diastolic, depending if we have narrowing of the heart valve or if we have redundancy of the heart valve causing regurgitation. Again, cardiac auscultation is so very important. Taking your stethoscope and listening to the correct placement is key to understand what you're actually hearing, and this just comes with time. Once you have heard what a significant aortic stenosis sounds like, you'll be able to recognize that more easily. Same thing with in the mitral area, making sure that you're actually truly listening in the around the apex of the heart. Mitral regurgitation also has a very distinct sound. Again, when we talk about valvular heart disease, we're talking about either stenosis or narrowing of the heart, or the narrowing of the heart valve, so the valve does not open, or regurgitation. Again, it's redundancy, and the blood can flow backwards. Mitral valve prolapse, or MVP, is a harmless valve sound and does not shorten life expectancy. Mitral valve prolapse usually doesn't need to be treated because it's rarely a serious condition, and it doesn't damage the heart at all. Depending on the severity of the mitral regurgitation or leakiness around the valve, that's when treatment may be warranted, and that's really when patients develop mitral regurgitation. Primary mitral valve prolapse is most often an isolated disease, but it can be linked to other valve or skeletal problems such as connective tissue disease. This is diagnosed by echocardiogram or ultrasound of the heart. Rheumatic heart disease is caused by bacterial infection, usually from strep A infections. Affects most commonly the aortic and mitral valves, but all valves may be involved. We don't see this too much here in the United States because of treatment for strep infections with antibiotics. However, in third world countries, this is actually more prominent. Another important aspect of the cardiac assessment is assessing for jugular venous distension, used to assess central venous pressure. We learned this in our health physical examination class. Causes of elevated JVD can be related to right ventricular failure, pericardial compression, tricuspid stenosis, a superior vena cava obstruction, circulatory overload, renal failure, excessive fluid administration, or an atrial septal defect with mitral valve disease. Causes of possible JVD that is lowered is dehydration and hypovolemia. Cardiac diagnostics, these are all of the testing that's very important to help diagnose cardiac conditions. EKGs, echocardiograms, or transesophageal echocardiograms called TEEs, chest x-rays, stress tests, cardiac catheterizations, CT scans, cardiac MRIs, tilt table testing, electrophysiology studies, and Holter and event monitors. For EKGs, we will have an entire lecture on EKGs in the lab portion of this of our cardiac class. We'll go over how to read EKGs and practice them. Chest x-rays are very important. They can show you the cardiac silhouette, looking for possible cardiomegalia or enlargement of the heart. In this picture, as you can see, we actually have a pacemaker in place. Echocardiograms, like I said, are ultrasounds of the heart. They will show 2D images, and now we can make 3D images of the heart. We're assessing for the heart structure and the valves. Echocardiograms use high-frequency sound waves to make these images. It shows the size and shape of the heart, thickness and movement of the heart walls. It documents the heart's pumping strength, which is documented as the LVEF, or the left ventricular ejection fraction. We're looking at the heart valves, again looking for regurgitation, leakiness of the valves, or stenosis, which is narrowing of the valves. It can also show tumors and infectious growth around the heart valves, problems with the outer lining of the heart, which is the pericardium. We will also see problems with large blood vessels that enter and leave the heart. We can see blood clots that may be in the chambers or either in the left ventricle or possibly the left atrial appendage. And we can also look for abnormal holes and tunnels between the chambers of the heart. These are atrial septal defects, or ASDs, or patent foramen ovalis, or PFOs. Transesophageal echocardiogram, again, this is a test. It's an ultrasound probe that the patient swallows. The esophagus sits very closely to where the heart sits, so we can get better close-up imaging of the same structures. Stress test. There are many different kinds of stress tests that you can order. The most simple test is just a treadmill EKG stress test. We can use treadmill and use medications to get better imaging. We can do myocardial perfusion scans. This is a test where a tracer is injected into the heart. We stress out the heart and another tracer is added, and they take pictures before and after. We also can do stress echocardiograms. Again, this can be also on the treadmill. We take echocardiogram pictures beforehand, have the patient exercise, and compare the pictures with ultrasound after the patient has stressed the heart. CT scans are used to make 3D images in the heart. We can look at the heart chambers. We can look at the pumping strength of the heart and also the coronaries. Cardiac MRIs, again, just more detailed imaging of the heart. We can look for scars within the pericardium or myocardium, again, assessing the 4 chambers within the heart. Holter and event monitors are used when we're concerned about heart arrhythmias. Holter monitors are usually worn for 24 to 48 hours. Event monitors are worn much longer. These can be worn for up to 30 days. And then we also have implantable loop recorders, or they're called links. These are small devices the size of a matchstick that can be actually implanted under the skin in the left chest wall. And they give us EKG tracings for up to 3 years. Tilt table testing is a test where we're evaluating causes of syncope or orthostatic hypotension. We evaluate the blood pressure and heart rate response at a 7-degree upright tilt for 20 to 30 minutes or until we notice a response. Sometimes during this test, vasodilators are given. We can either use isopril or nitroglycerin tablets. And this really kind of tricks the body to, it pulls the blood to the lower extremities. The heart should compensate, however, for some causes of syncope or neurocardiogenic issues. The body is not able to adapt to those changes. Cardiac catheterization is X-ray imaging, where we inject contrast directly into the heart arteries to get a visualization of the left and right coronary arteries, looking for specifically blockages within the arteries. This is just an image of the coronary anatomy. As you can see, we have three main branches of the coronary arteries. We have a branch that comes off the aorta to the right side of the heart called the right coronary artery. We have a main artery called the left main that branches to the left coronary artery into the left circumflex. This supplies the blood flow to the actual heart muscle. Cardiac catheterizations, remember that there are medications that should be held prior to heart caths. For example, metformin or glucophage. You need to stop taking the drug on the day prior to the procedure and not to resume it for at least 48 hours after the procedure. Also, anticoagulants, Coumadin, warfarin, and NOACs are held prior to the cardiac cath, dependent on the drug and dependent on the cardiac interventionalist who is performing the test. Also remember that we are using dye or contrast for these procedures. So if a patient has an allergy to contrast, they need to be pre-medicated. That dosing is prednisone 50 milligrams given 13 hours, 6 hours, and 1 hour prior, and Benadryl given 1 hour prior to the cardiac catheterization. Electrophysiology studies, these are done for patients that have heart arrhythmia issues. We do 3D mapping of the heart. We can determine the electrical system of the heart and look for abnormalities that we may be able to cauterize or freeze within that area to disrupt the electrical system. All right, now we'll get into some diagnoses. Probably the most common is chest pain. I think the most important thing to remember is when you're assessing the patient, is it a life-threatening condition? So those include acute coronary syndrome, myocardial infarction, myocardial ischemia, aortic dissection, pulmonary embolism, and pneumothorax. Also remember, when patients come in with complaining of chest pain, after you have ruled out a life-threatening condition, to go through your differential diagnoses, which include pulmonary, GI, psychological, musculoskeletal, esophageal spasm, GERD, and pericarditis. I've added, again, some case studies within these slides. I'm not going to read all of them. You can print them off and go through them. And if you have any questions regarding the case studies, we can go over these further in our in-class lab time. Again, if you have a patient with chest pain, there are very key questions to ask. Things like your old carts, so thinking about having the patient describe the pain, what does it feel like specifically. I always ask patients to point with one finger where the pain is. Does the pain radiate? Is the pain worsen with exertion? Exactly when did it start? What makes the pain better? What makes the pain worse? And what other attributing symptoms does the patient have? Coronary artery disease or blockages within the heart arteries is leading cause of death, of cardiovascular deaths, responsible for more than 1 out of 4 deaths, approximately 600,000 patients a year. Mortality has declined due to patient education, early recognition, early treatment. This is our door to balloon time. We want to get these patients into the ER right away to be seen and sent to the cath lab so we can open up the vessel quickly, and aggressive management of risk factors. These risk factors include male gender, increasing age, previous family history of coronary disease, especially in patients that have family history of early onset, that's less than 60 years of age, patients that are hypertensive, smoking history, sedentary lifestyle, diabetics, stress, which is on there twice, and hypertension. That's how important it is. Again, acute coronary syndrome, so myocardial ischemia. You'll hear the terms STEMI and non-STEMI. A STEMI is an ST elevation myocardial infarction, and a non-STEMI is when the ST segments are not elevated, but they still may have elevation in troponins. There's also stable angina, unstable angina. This is chest pain that occurs with exertion. And myocardial infarction, which is that the tissue has already died. There's obviously, we diagnose STEMIs and non-STEMIs by EKG. You'll see the evolution of a MI occurring on EKG. Dependent of where the ST elevation is on the EKG helps determine exactly where or which coronary artery could be involved. If you're planning on working in cardiology, this slide is very important for you to memorize. So if a patient comes in with a STEMI or non-STEMI, like I said, it's important for us to get the patient to the cath lab as soon as possible so that they can undergo percutaneous coronary interventions. This is when we diagnose the affected artery or arteries. They can balloon the artery open and then put a little metal mesh in there called a stent to increase perfusion to the heart muscle. If a patient does receive a percutaneous intervention like a stent, patients need to be on dual antiplatelet medications. That includes aspirin, Plavix, Effient, or Brilinta, and they need to stay on those medications for at least 12 months. They also need to be started on beta blockers, statins. I always prescribe nitro tablets for these patients, and patients that have continued issues with angina, they may need to be started on long-acting nitrates, and these include isosorbide and Ranexa. We'll also do an echocardiogram to assess the LV function to see if there's been damage to the left ventricle. Be really important to go over with your patient any lifestyle modifications that they will need to make now in the future. And we will always refer these patients to cardiac rehab. Now, my favorite topic is heart arrhythmias. As you all know, I currently work in electrophysiology, and this is what I deal with every single day. So remember our cardiac conduction. We have, remember the SA node is the pacemaker of the heart. It causes depolarization, repolarization of the heart muscle. So the heart the electrical impulse starts at the SA node. It goes through the AV node, through the bundle of His, and then through the Purkinje fibers to contract the right and left ventricle. Again, just another schematic of what the actual electrical system looks like within the heart. So some of the most common heart arrhythmias, the first one is atrial fibrillation. It's quite common. It's 2.2 to 5 million Americans have atrial fibrillation, and that number is continuing to increase with the baby boomers. And you can see as patients age, their chance of having atrial fibrillation increases. There's a wide range of predisposing factors. A most common clinical diagnosis associated with atrial fibrillation are hypertension, CAD, and obstructive sleep apnea, factors that trigger the arrhythmia, and factors that perpetuate the arrhythmia. This is rapidly firing cells in the atrial myocytes coming from the atria. We always look at left atrial size when we're assessing these patients via echocardiogram and CT scans. The hemodynamic effect of atrial fibrillation, there's lots of atrial contraction, so you have more of a quivering of the upper chambers of the heart. You can have rapid ventricular rates. That's usually the part that that's why patients become so symptomatic, is because the ventricular rate increases. There's loss of AV synchrony, loss of stroke volume, and LV contractility. These patients may or may not feel their atrial fibrillation. Some patients will complain of the effects of atrial fibrillation. Again, atrial fibrillation is characterized by disorganized atrial activation. You'll see on EKG that when you have atrial fibrillation, the P waves change with morphology. The ventricular rhythm is irregularly irregular. Most AFib originates from the pulmonary veins, or possibly a reentrant focus within the left atrium. This is seen obviously on EKG. It's the only way that we can truly diagnose atrial fibrillation, and is best seen when you're looking at V1. And you'll have ventricular rate variabilities dependent on the autonomic tone. So as I was saying before, patients may have significant fluttering in their chest. I have patients that know the exact moment that they are out of rhythm. And they can have profound hemodynamic deterioration. Some of these symptoms include congestive heart failure, dyspnea, chest pain, lightheadedness, dizziness, increased urination, flash pulmonary edema. Patients will complain of palpitations. Besides just the rate of atrial fibrillation, the other aspect of this that we are most concerned about is the CVA and stroke risk. What happens is, because the upper chambers of the heart are not contracting as they should, the left atrial appendage is an area where clots can form. And this is why we put patients on anticoagulants when they're first diagnosed with atrial fibrillation. Again, to assess the left atrial appendage, looking for thrombus, we either need to do an ultrasound or an echocardiogram versus a transesophageal echocardiogram. Atrial fibrillation is determined by three types, and it's very important to know these three types when you're describing patients with atrial fibrillation, because treatment options are very different. So paroxysmal atrial fibrillation comes and goes on its own, may last for seconds, minutes to hours, or even several days before the heart returns to a normal sinus rhythm. There's persistent atrial fibrillation, which atrial fibrillation does not stop by itself and lasts more than 7 days. Medications or cardioversion is required to return the heart back to normal sinus rhythm. If the persistent AFib lasts more than 1 year, this type of atrial fibrillation is called long-standing persistent AFib. And then, sorry about that. And we also have permanent atrial fibrillation, where the normal heart rhythm cannot be restored, and only a rate control approach will be used. And this is often dependent on the patient's symptoms. Just remember, the longer your heart is in atrial fibrillation, the more difficult it is to get you back into normal rhythm. So for us in the electrophysiology world, we like to see patients as soon as they're diagnosed with atrial fibrillation, so we can manage these patients appropriately. Again, atrial fibrillation is diagnosed by catching this on either event monitors, Holter monitors, telemetry monitors, EKGs. Now Apple Watch does have, the new Apple Watch does have a component where you can place your finger on the side of the Apple Watch, and it will give you a one-lead EKG tracing. And we have actually caught many patients using this method and diagnose their atrial fibrillation. Again, remember, so atrial fibrillation can starts at the upper chambers of the heart, can come from the right and left side of the heart. Again, most atrial fibrillation does start from the connection from the pulmonary veins on the left side of the heart. But you can have focal areas within the atria. Again, here's some EKG evidence of atrial fibrillation. We'll go over this in more detail during our EKG lecture. So once you have a patient that has developed atrial fibrillation, we need to determine anticoagulation for them. So we use what we call the CHADS-2 score, the CHADS-2 VAS score. This will determine patient's stroke risk. And these are all the factors that increase a patient's stroke risk. Many times now we're just using the CHADS-2 VAS score. Things that we're looking at is heart failure or left ventricular ejection fraction less than 40%, hypertension, age greater than 75, diabetes, if they've had a previous stroke, vascular disease, again, age 65 to 74, and females also get an extra point because their stroke risk is higher. So once you have determined if a patient would benefit from anticoagulation, and so we're looking for patients that have a CHADS-2 VAS score 2 or above. These patients should be on long-term anticoagulation. Then we need to decide what medication would work best for these patients. We have warfarin, Pradaxa, Xarelto, and Eliquis. Pradaxa, Xarelto, and Eliquis are the new novel agents. And we'll go in more detail about these. So before we had the novel agents, the only anticoagulant we had was warfarin or Coumadin. Remember that this medication is what is found in rat and mouse poison. So when you have a patient on Coumadin, you need to monitor their INR levels. Their goal INR is between 2 and 3 for AFib flutter patients, and also for patients that have DVT and PE. If a patient has a mechanical valve, remember their INR goal is 2.5 to 3.5. The table shows how to prescribe warfarin or Coumadin to patients. In our clinic, we actually are very fortunate to use our Coumadin clinic, and we partner with our pharmacists to help manage these patients. They can become quite tedious, especially when you're first starting this medication to get to a level or a dosing strategy that works best for the patient. There are times that patients with atrial fibrillation are not able to take long-term anticoagulants. There's a new procedure that we now have called the left atrial appendage closure. This is called the Watchman device. This is for patients that have a CHADS-VAS score of 2 or greater and unable to continue taking oral anticoagulation for long term. This can be because of recurrent GI bleeding, nosebleeds, hematuria, patients that have had, we've treated patients that have had subdural hematomas. They can have high-risk lifestyles, such as patients that are avid motorcycle riders, Arnold Schwarzenegger actually has a Watchman device, and his reasoning was because of all the stunts that he performs. So he was able to get approval for a left atrial appendage closure. If patients are at high risk for falls, this is another reason why patients could be referred for this device. So again, treatment for atrial fibrillation, first we need to rule out a left atrial appendage thrombus. So we use TEE and TEE prior. Once that has been ruled out, then we can do a cardioversion. We just need to make sure that if you have a patient, you want to get them out of atrial fibrillation, they need to first, if they have not been on oral anticoagulants, we need to start those, and they need to have a TEE and cardioversion first, and then they need to be on anticoagulants post cardioversion for at least 1 month, no matter what their CHADS 2-VAS score is. The other approach to this is that if a patient has been appropriately anticoagulated, prior, they do not need the TEE. They can just have a cardioversion. So they need to be, they need to have 1 month or 3 to 4 weeks of consecutive therapeutic INRs, or 3 weeks of uninterrupted novel anticoagulants. So the treatment options for atrial fibrillation is either rate or rhythm control. The interesting part is that there is no significance in mortality between patients that are in atrial fibrillation as long as the rate has been controlled compared to patients that we get back into normal sinus rhythm. The added benefit is the patients have a better quality of life when they're in normal rhythm. So we can use for rate control strategy only, we can use beta blockers, calcium channel blockers, and digoxin. Then we also have antiarrhythmic medications. These are medications that we use to keep patients in normal rhythm. We have sotalol, Rhythmol, amiodarone, Maltac, flecainide, Ticasin, and then also a pill-in-the-pocket approach where patients, if patients are highly symptomatic and know exactly when they go into atrial fibrillation, they can take high doses of flecainide or Rhythmol, and these medications will convert the patient to normal rhythm. Again, both, no matter what, if you're treating patients for a rate control strategy versus a rhythm control strategy based on their CHADS 2-VAS score, you need to make sure that they are anticoagulated. Again, this is a chart that discusses rhythm control in patients with paroxysmal or persistent atrial fibrillation. So when you decide on what medication that you would like to try, you need to make sure that they have no structural heart disease. So many times these patients need to have an echo beforehand and either have had a stress test that has showed no significant heart disease or a cardiac catheterization. I don't expect, as a family nurse practitioner, unless you're working specifically in cardiology or electrophysiology, that you will be prescribing any of these medications. But to know that your patients may be on these medications and they may come and see you for other reasons or possibly develop structural heart disease or heart failure in the future, and these medications may need to be stopped. This is just an echocardiogram picture that shows a appendage that has formed in the left atrial, a clot that has formed in the left atrial appendage. Other treatment options for atrial fibrillation, when we have difficulties controlling patients' heart rate, or we're not able to keep them in rhythm, patients may develop what we call tachybrady syndrome, and a pacemaker may be indicated so that we can adequately treat the patient with higher doses of antiarrhythmics without the concern of causing significant bradycardia. The definitive rate control treatment that we have is an AV nodal ablation. This is where we go in and cauterize the AV node, and patients do become dependent on a pacemaker. There's some surgical treatments. There's epicardial ablations, where a surgeon may cauterize the outside of the heart during surgery, or a maze procedure. These are done sometimes when patients are already scheduled for open heart surgery for other reasons, and the surgeon can very quickly cauterize the outside part of the heart to help reduce the chance of atrial fibrillation. And then we have catheter ablations. We can use radiofrequency or cryo or cold. This is where we go inside the heart and actually cauterize around the pulmonary. We map out the electrical system of the heart, find out where the atrial fibrillation is coming from, and we cauterize, or we actually freeze that area to cause scar. Again, catheter ablations are not curative. Atrial fibrillation can return. So again, ablation therapies, these are just some pictures that show kind of how we do perform these procedures. This image just shows the ablation of the AV node. Again, when we do this for definitive rate control, the patient does become dependent on a pacemaker. The sister arrhythmia that's very similar to atrial fibrillation is atrial flutter. Again, this is rapid atrial rates, but these are this is actually more regular. The atrial rate can be quite fast, 240 to 340 beats per minute. You'll see on EKG the classic sawtooth pattern. We can have atypical atrial flutter. This is atrial flutter that is actually occurring not from the right side of the heart, but from the left side of the heart. Many times atrial flutter is paroxysmal. Causes and treatments are very similar to atrial fibrillation. Catheter ablation is actually very highly successful for atrial flutter. Here again is EKG evidence. You can see the very typical sawtooth waves. Other heart arrhythmias that we are concerned about, one of the most concerning is ventricular arrhythmias. Again, these can happen. I always tell patients that it's because they have a short circuit within the bottom part of the heart, or within the ventricle. This can be caused by scar or a genetic abnormality. Again, another case study that I will let you guys review on your own. This chart, and I actually added it to your module so that you can print out to have. These are all the antiarrhythmic medications and the von Williams classifications, and the dosage and the indications for these different medications, along with the side effects and warnings. There are several classes of antiarrhythmic drugs, class 1A, 1B, 1C, class 2, 3, and class 4. These are all very important because you need to monitor frequent EKGs. Looking specifically for QT prolongation and bradycardia. The other aspect of antiarrhythmic medications, that if you do have a patient on an antiarrhythmic, they should not be having any further heart arrhythmias. This includes atrial fibrillation, atrial flutter, ventricular arrhythmias. And if they are continuing to have those heart arrhythmias, then the antiarrhythmics are no longer working, and they either need to be switched to a different class if possible, or these medications need to be stopped and another treatment option suggested for these patients. When you are prescribing antiarrhythmic medications, or you have patients on antiarrhythmic medications, you need to be very concerned about other classes that can actually affect the QT, causing worsening arrhythmias. Obviously, other antiarrhythmics. If a patient's on another antiarrhythmic, they should not be on a combination of two antiarrhythmics. I see this every once in a while being done within the hospital. There's some antipsychotics and antidepressants, antibiotics, antifungals, antihistamines, opioids, GI stimulants, and some other miscellaneous medications that you need to be concerned. If you do have a patient on an antiarrhythmic medication and you happen to see them for another reason, you need to make sure that the medication that you're prescribing is not going to prolong the QT. A medication that, an antiarrhythmic medication that I believe is used too often, and some people feel like is the first line medication for these arrhythmia patients, which we should not be using as a first line medication. In the EP world, we feel like amiodarone really should be saved as a last antiarrhythmic medication if possible. And the reason for that is there's many long-term side effects of amiodarone. These patients, when you prescribe this medication, they need to have baseline assessment, including PFTs, chest x-rays, hepatic panels, thyroid panels, and eye examinations. And then surveillance. In surveillance, you need to continue to monitor LFTs, TSH every 6 months. They need to have yearly PFTs and chest x-rays. And also remember that amiodarone will affect INR levels. Again, another case study I will let you review. So the other part of electrophysiology that I see quite a bit in my practice, obviously, is patients that have pacemakers and defibrillators. Pacemakers and ICDs or defibrillators. There's actually now many options for patients. Remember, all ICDs or defibrillators are pacemakers, but not all pacemakers are ICDs. And then with that even being said, not every pacemaker and defibrillator is doing the same thing. So pacemaker and defibrillators can have 1, 2, or 3 wires. We actually now have some devices. The picture in the middle is actually a Micra leadless pacemaker. It's a small little pacemaker that we can implant going through the groin to the right ventricle of the heart. And the battery life is 8 to 10 years. For this, it just stimulates the ventricle. We also have subcutaneous ICDs or defibrillators. These are devices that are placed actually on top of the ribs. We try to go just below the axilla area, and the wire actually goes up the sternum so that there's no wires within the heart. Then the next aspect is we need to discuss in detail is heart failure. Remember, heart failure is a term used to describe a heart that cannot keep up with its workload. It's a very generic term. Many patients, providers kind of use this term anytime patients have increased volume status. To understand heart failure in its entirety, you need to understand the pathophysiology of heart failure. I love this slide because it gives a good a schematic of actually what's happening. So we're looking at the inability of the heart to provide sufficient output to meet the demands of the body. There's a variety of disorders that can lead to low output or high output failure. We will see pulmonary and systemic venous congestion. We will have an increased sympathetic nervous system activation. ADH gets secreted from the brain. We have increased afterload and possibly increased preload. We have cardiac dilatation and hypertrophy. And there's neurohormonal responses that will also worsen heart failure. Heart failure can be precipitated because of many causes. The most prevalent is ischemia of the heart, but we can see heart failure in patients. We can see heart failure symptoms in patients that have anemia, infection, pulmonary edema, pregnancies, issues with the thyroid, arrhythmias, rheumatic heart disease, valvular heart disease, infective endocarditis, environmental causes, toxins, stress, which is called Takotsubo, hypertension, diastolic dysfunction, which is when the heart doesn't relax. We can have hypertrophic changes of the heart and congenital heart disease. Heart failure assessment, we definitely want to assess for JVD, heart tones, listening for additional heart sounds such as S3s and S4s, or if the heart tone is irregular. Breath sounds, you will hear rhonchi and rales. We'll see a lower extremity edema, abdominal distension, hepatomegalia, splenomegalia, poor PO intake, orthopnea, and PND. If you have a heart failure patient, you need to always classify them. So there's the nomenclature is getting changed currently. We have heart failure with reduced EF or HFrEF. This is systolic heart failure. This is when patients have a documented left ventricular ejection fraction. Remember, we get that number on echocardiogram that is less than 45%. We can also have heart failure with preserved EF or HFrEF. These are patients that have diastolic heart failure, and they may have a normal left ventricular ejection fraction. Again, another great image that shows you kind of the differences in systolic dysfunction and diastolic dysfunction. I'm not going to go over all of these, but I would definitely take a longer look at this slide. Again, when we are first classifying heart failure patients, the number one test that we need to do is an echocardiogram to evaluate the left ventricular function of the heart. Along with describing if a patient has either heart failure with preserved ejection fraction or reduced ejection fraction, or systolic or diastolic heart failure, you also need to classify the severity of the heart failure. So we have the New York Heart Association classification. So if a patient is class 1, these are patients with asymptomatic heart failure. That would be all of us currently. Class 2 is patients with heart failure symptoms with significant exertion. Class 3 is patients with heart failure symptoms with minor exertion. Or class 4, patients with heart failure symptoms at rest. Again, this is just going over, again, the New York Heart Association classification. Anytime that I have a patient that has a diagnosis of heart failure, I always will document what class they are in. This is important because obviously you want your patient to be at least class 1 or class 2, but if you have a patient that comes in, they are class 3 or class 4, you treat them, you want to make sure the next time that you see them that they have improved and their classification has changed. There's also ACC/AHA staging criteria of heart failure. These are patients that are at risk for developing left ventricular dysfunction. These are patients that have comorbid conditions that will put them at risk of developing heart failure in the future, possibly developing heart failure in the future. So we have A, B, C, and D. ACC/AHA stage D are patients with refractory and end-stage heart failure. These patients should be referred to palliative or hospice care. If you have a patient that is class B or C, these patients need to be evaluated by cardiology or a heart failure specialist. We also can have heart failure symptoms coming from the right because of right-sided failure of the heart. When you have right-sided failure, you may see different symptoms when you are assessing these patients. When patients have right-sided failure, you're going to see worsening congestion of the peripheral tissues. They will have edema and ascites. They will have complaints of GI tract congestion. They will have poor PO intake, weight loss, anorexia, and significant liver congestion. This is different than when patients have left-sided heart failure symptoms. This is when you have patients that will have more pulmonary congestion, orthopnea, cyanosis, and signs of hypoxia. Remember, you can have patients that start out with left-sided heart failure, but over time, because of the fluid that has backed up, it's going to start to affect the right side. You'll start to see some right-sided heart failure symptoms. Important labs to consider when you have a patient that is that you fear has a diagnosis of heart failure. You need to obtain a BNP. BNP, TSH, liver function test, CBC, and cardiac enzymes. BNP is the B-type natriuretic peptide. The levels of BNP and proBNP will go up when patient's heart failure is worse, and should go down when it is better. You need to have really EKG, chest X-ray evidence of heart failure and an elevated BNP to truly state that a patient does have heart failure. So when you have patients with a possible diagnosis of heart failure, you've done echoes, EKGs, you've gotten labs, the next part of this is to figure out the cause. There are many causes of heart failure. I think there's like 150 different causes of heart failure. Obviously, the most common is coronary artery disease, hypertension. Cardiomyopathy is a description of what the left ventricle looks like. It can just be dilated because of congestion. It can be hypertrophic or restrictive. You can have valvular or congenital heart disease, different arrhythmias, alcohol, and drug use. So dependent on the specific cause of heart failure, that's going to drive your treatment of these patients. However, with all heart failure patients, and especially heart failure patients with reduced ejection fractions, there are medications that have been proven to reduce mortality in these patients. These include ACE inhibitors, ARBs. Entresto is a new medication that has recently been found to reduce patients' symptoms of heart failure and improve their ejection fraction. We have beta blockers, aldactone, diuretics, digoxin, and inotropes. So heart failure management, again, these patients need to be really followed by cardiology and heart failure specialist. One key factor, if a patient, their ejection fraction has not improved, they may be considered for defibrillators or cardiac resynchronization therapy. These patients will have repeat echoes, reevaluating the left ventricle to see if there has been improvement in the pumping function. Patients need to weigh themselves daily. You need to definitely know what the patient's dry weight is, and that's where they should really try to keep their weight. They should be doing home blood pressure and heart rate checks. They need to follow a very strict low sodium diet. We need to assess for medication compliance. Again, referring these patients on to heart failure specialists or heart failure clinics. And our ultimate goal is to reduce hospitalizations for these patients. This is a great slide. This shows the different stages of heart failure and the typical time and like survival of these patients. So you can see if you have a patient that some patients may have periods without symptoms and then have their first period or episode of heart failure, and then we work hard to get those patients back to what will become their new normal. And you can see over time they will just continue to have a decline. Just another aspect that I want to touch base on is cardiovascular surgery. These are the procedures that surgical procedures that patients can have done. Sorry about that. These are procedures that patients may have done to repair an abnormality of the heart structure, a coronary artery bypass grafting surgery, procedure where the surgeon will bypass a blockage in the heart arteries to help with perfusion. Patients can have valve replacements or valve repairs. There's minimally invasive surgeries and now transcatheter valve procedures where we can use small incisions through the groin, use catheters to replace heart valves. And in some patients that have end-stage heart failure, now we have left ventricular assist device that these are devices that patients can actually wear as they're awaiting heart transplant, or actually now used for destination therapy, where patients can now live with left ventricular assist device even without having a heart transplant done. Another case study I'll let you review. All right, the last section that I want to touch base on very quickly is peripheral vascular disease. This is a circulatory condition in which the narrowed blood vessels reduce blood flow to the limbs. These are patients that may have complaints of pain with ambulation or claudication. You may notice discolorization of the lower extremities. They may have cold extremities or lack of leg hair. Treatment is obviously to improve blood flow by either using medications or angiograms or stents placed in these areas. So what patients are at risk of developing peripheral vascular disease? These are diabetics, people over the age of 55 to 60s. Males are more prone than females, hypertensive patients, smokers, people with high cholesterol, and obese individuals. DVT or deep vein thrombosis is clots that have formed in the venous structure of either lower extremities, or I've seen many patients have DVTs in upper extremities. So the whole goal of this is of these patients is to treat them with anticoagulation. We talked earlier about using warfarin or Coumadin for patients, or even the novel agents. There's also catheter-assisted thrombolysis treatment that can be used. This is a procedure where a catheter is guided through the vein and delivers ultrasound energy to break up the clot. DVT risk factors: patients that have had recent surgery, hospitalizations, advanced age, obesity, patients that are immobile, patients that have clotting disorders, pregnancy, estrogen-containing contraceptives, tobacco use, prolonged air travel, cancer, and infection. Carotid artery disease. This is blockages of the arteries, the carotid arteries. You can diagnose this by auscultation of a bruit. That's not 100% diagnostic, but it is a useful clinical sign that if you do have a patient with a bruit, you need to make sure that they have been evaluated by ultrasound or CT scan or MRIs, and remember that the sound becomes softer as the stenosis increases. Again, management of carotid artery disease. if a patient's had a stroke, you obviously want to be more aggressive with the management. However, if you have patients that have minimal blockage, this graft is very helpful to when to consider just doing surveillance, carotid ultrasounds or CT scans, or when to refer for possible revascularization. Another case study I'll let you look at. Aortic dissection and aneurysm. Remember, dissection is a tear in the aorta compared to an aneurysm where there's an outpouching or ballooning of the aorta. Both of these diagnoses are emergencies. If you have a patient with an aneurysm, they need to be followed very closely by vascular with routine and surveillance CT scans. High-risk patients or patients that have had family history of dissection or aneurysms need to be screened, along with patients that are male, over the age of 50, and smokers. All right, that was a lot of information in a brief amount of time. Each one of those sections I could probably spend hours lecturing on. Hopefully this will give you kind of just a brief overview. Again, if you have any questions, please let me know. But some of my tips for when you see the cardiac patient in the office, especially if you have someone that is coming in with a significant complaint. Remember to know your worst case differential diagnoses. Anytime when in doubt, refer to cardiology or EP or vascular specialists. And if the patient comes in and things just don't feel right, definitely ask questions and evaluate the patient with ongoing labs and diagnostic examinations.